the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Welcome back, listeners. Today we continue our discussion of overuse injuries in pediatrics with Dr. Randon Hall. Welcome back, Dr. Hall.
Thank you. Thanks for having me.
Let's keep talking about pediatric overuse injuries in sports medicine. I'd like to talk about some of the injuries of the knee. If you've ever had to take a PA certifying exam, they like to put in old people's names, like Osgood-Schlatters disease. And I'm giving away our next topic, but that has been a question on every exam I've ever taken for a PA. I don't know how it works in the MD world, but for PAs, no Osgood-Schlatters, even if you don't do orthopedics. Could you please talk a little bit about Osgood-Schlatters and then Sinding Larsen-Johansson, or SLJ, and just kind of compare those two?
Yeah, so for Osgood-Schlatters, I agree. We see this super frequently, and I think it does lead to some high yield questions. The main thing that I think one is just establishing again that it's not a disease, it's just named after someone. And then I think this is a good time to maybe point out that growing pains is different than pain at the growth plate. So if you are to describe this to your patient as growing pains, I would politely say that's inaccurate, and I would use the term pain at the growth plate, because growing pains is a separate thing, a separate entity, but pain at the growth plate is much more accurate. The reason why I do that is because a lot of times people think, oh, growing pains, there's not anything I can do about this, whereas Osgood-Schlatters is much different. So tibial tuberosity, apophysitis, I find tends to happen at a little older age group. So maybe in that 12 and above age group into high school is when we'll see this. It can be bilateral, but it also can be unilateral. And sometimes people just present with these lumps or bumps on their knee. I've also found that it kind of comes in a few different flavors, where sometimes people will say, if I'm doing physical activity, it doesn't hurt, but if I kneel down, it does, or vice versa. If I put pressure on it, it doesn't really hurt, but if I do activity, it does give me pain. And then people can just have both. So I make sure to say that it does come in a different varieties, and it's the long game here, just like calcaneoapophysitis, making sure the families know that we're going to try activity modification. I do think stretching is useful here. So basically, if you've got tight hamstrings, your quad has to pull a lot harder against that tibial tuberosity. And so I really emphasize and show the families, like, look, I get down and stretch. I say, hey, I'm 42 and I can get down to the toes, and you're 15 and you can't get past your mid shin. So like that's something we need to work on. So stretching is very useful in this scenario, pain modification. And then I do think the patella strap can be helpful. But if I'm being very honest, I think it's probably more of a placebo or gait control theory pain, where you have something tight around the patella tendon, and that may distract from the pain at the tibial tuberosity. There is some kind of physics theory that pressure at the tendon will relieve pressure at the tibial tuberosity, but I just don't see that that's completely accurate. So that's kind of how I'll approach these patients. Obviously, if they have limp or pain greater than 3 out of 10, I'll shut them down. And then SLJ, I will say this tends to be much more mild, and it tends to be in much younger patients. And so same kind of general, what I call common sense approach to this diagnosis. But I think expectations here are that we should see some improvement over the next few weeks to a month, whereas with Osgood's, sometimes it might be 6 months, it might be 9 months. There may be days where you feel great, and then you have a tournament and it feels bad again. So I really try to put that out there, but I would say that that's the main difference, is age, and then severity and length of expected pain is how I would approach these. I did want to add one thing about exam. I think this is why it's important to be very consistent and repetitive about your exam. So if you assume it's patella tendonitis or something, you're going to find that on your exam. But if you do tibial tuberosity, patella tendon, lower pole of the patella on each patient each time, you will start to see that they can discern with that 1, 2, and 3 of where the pain actually is. And that can be very helpful in giving the patient expectations.
That's right. If you don't really squeeze the tender spot, how do you know where it is? All right, Dr. Hall, let's talk about patella tendonitis. It's classically called jumper's knee, but I see it in a lot of different folks, a lot of different activities. What's your experience with it? And I also wanted to talk a little bit about your slides where you had an ultrasound that showed thickening of the tendon, and you talked about doing a percutaneous tenotomy. So I was hoping you might review some of that with our listeners.
Yeah, I would say anecdotally, we see patella tendonitis, so the itis, not tendinopathy that I'm talking about. We see the patella tendonitis a reasonable amount, but it's not as common as some of these other growth plate irritations. Remember, all of the forces coming through one, kinetic chain. And so with that, if the growth plate is still open, so like for Osgood-Schlatter's, we would tend to see that over patella tendonitis. And so I think that's important to make sure your exam is crisp and precise. Where I will see this is in these older growth plate closed patients. So kind of that 14 to 18 age group is where I'll see this. When we see just the general tendonitis, x-rays are negative, growth plates are closed, our ultrasound is normal, that common sense treatment plan that we talked about is usually quite helpful. Where you will see this tendinopathy is patients may say, hey, I've had this pain for 2 years. I've had it for a year and a half. And it's usually going to be most at the very proximal pole of the patella tendon. So not necessarily on the actual lower pole of the patella, but at the very proximal aspect of the patella tendon. And it usually will be quite painful. Visually, you'll see the patient pull back. And that's where I start to go for the ultrasound to see if this is actually tendinopathy. So a degenerative process of the tendon, like you may see in the adult patients, this is where we definitely see it in our pediatric patients. And it is a very simple ultrasound to do. The beauty here is that you can always compare to the unaffected side. If you have any familiarity with ultrasound, you should be able to tell what normal tendon looks like. And in this case, the patient will have abnormal tendon. So a normal tendon is kind of hyperechoic, so bright white lines, whereas a tendinopathic tendon is dark or hypoechoic. It's thickened. It may have increased neovascularization or Doppler flow within that. All things that kind of sound super complicated, but it's pretty straightforward to do this if you have any ultrasound experience. And then usually what we will do is try a different approach. So rather than the itis kind of calming down the inflammation, we will try a more eccentric protocol in physical therapy. And that's why it's important to know whether you're dealing with itis or tendinopathy. So basically, we want to stimulate new tendon fibers in that area to help replace that tendinopathic tissue. And sometimes eccentric squats can be helpful, but sometimes it just doesn't do anything. And that's where we will go and do an ultrasound guided tenotomy. And that process is basically numbing up the tendinopathic area under ultrasound with lidocaine, and then using an 18 gauge needle with some normal saline and just fenestrating that area. So we're just going in and out in the long axis, and then in and out in the short axis. And by out, I just mean out of the tendon, but still inside the skin. And you're just tenderizing that tendon, trying to disrupt it and allow the body to recreate new healthy fibers. And sometimes it works, and sometimes I need to refer them on to some other colleagues who do some other more aggressive procedures where they do the needle tenotomy with a ultrasonic machine that helps to actually remove the tissue. and that can be quite useful. I just know my strengths, and I would probably only do that 1 or 2 times a year. So I would pass that on to someone who does it more commonly, usually one of my adult colleagues.
I remember working with a sports med doc that we sometimes did just surgical debridement of that to try to help. So yeah, it's really thick. It can be really thickened. IT band syndrome. Dr. Hall, you talked about your own experience with this, and I can testify that the older you get, the more likely you're going to have some of this stuff. And once you've had it, you kind of know what it is. I'd seen it in Army recruits. There's a Fort Bragg that's not far from where I live, and a lot of recruits marching and running in boots and that kind of stuff. And you talked about doing some stretching exercises for this and rehab. Have you ever considered an injection, or have you ever tried an injection, a cortisone injection? I have, and it hasn't been that many times. This is an adult population, not a pediatric, but injecting around Gertie's tubercle. What are your thoughts on that?
Yes, I actually have had this myself, and it can be extremely painful. I would say it gets to a bigger question of like how often I'm using corticosteroid, but I think in the pediatric population, I can say I've done this twice, and it's had good result. But I got to pick the right patient. You got to know that they've done all the things that you needed them to do on the front end. But I would say I have no problem doing an injection at Gertie's tubercle if the patient has failed all the other conservative management. But I would say most of the time they will get better with extensive stretching of the IT band, as well as manual treatments and looking at their functional gait analysis. All can be done at PT. But yeah, I would say no problem doing that, but I would favor a good, healthy, rigorous stretching program and functional evaluation over an injection. Because again, remember, we want to really teach that the kids can get out of this themselves rather than just coming back every time. And I realize it's different in adults, like people have to go to work, they have to make their money, they have to like it's a little bit more, we need a solution now as opposed to a young athlete. And so that's my approach.
Got it. And let's see. Patellofemoral syndrome. So I wrote in the script anterior knee pain. I like this about as much as the foot and ankle docs like the second toe problems and and back pain. It's just it's tough to manage. It's super common, seen it a million times, but it's just a tough thing to manage, or at least in my experience. And I'm just curious, how do you do it? How do you manage these? I liked your discussion and your algorithm. Could you please share that with our listeners?
Yeah, I think this case of anterior knee pain is as much psychology as it is musculoskeletal medicine. I think really setting the tone of doing that extensive history, doing the physical exam. But I like for the families to see that, yes, we all know that this patient doesn't have a torn ACL, but you never know what the family is thinking at that time. So I go through a full exam, Lockman, McMurray's apprehension. Like I show them and I say, it is not this, it is not that, because the families will feel like, well, how can they have pain for so long and it hurts so much? And I'm making air quotes here, you're saying nothing is wrong. And I just really like to make sure that I illustrate it to them that there is no findings that are consistent with anything that is surgical. So that kind of just takes a weight off of them. And then I go through and I like to set them up. So I like to say, hey, we have patients that have this type of symptoms and they have pain when they go upstairs, when they sit in a chair for too long, when they run for periods of time. And those patients can be really frustrated. Is that similar to what you have? And the head starts shaking. And so they feel like they are part of a bigger group of kids who share the same diagnoses. And I think that can be helpful psychologically. I also go through and show them, let me see a single leg squat. And I just tear it apart. I say, okay, look, you're leaning to one side, your knee goes in. Because the athlete, when they come in, they think they're a great athlete, they think they're fit, they think they condition, and it can be something where you can show them, yes, I know you're a high level athlete, but you have these deficits that are leading to this knee pain. And so those are the strategies that I use to illustrate why I think it is what it is. And then I also make sure that I get up underneath that kneecap, press on that medial facet, and I want everybody in the room to say, yep, that's the spot. And I say, that's exactly where I would expect you to have pain. So just making it real to the patients and not just kind of this generic gloss over like, yeah, you have some tenderness over your knee, because I think that families need the confidence to go forward rather than glossing over that they don't need surgery.
Dr. Hall, great discussions. Great discussion. Listeners, stay tuned for next week when we continue our discussion of overuse injuries in pediatrics with Dr. Randon Hall. Please follow the Physician Assistants in Orthopedic Surgery on social media. Connect with us on Facebook, Instagram, LinkedIn, and Twitter. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.